Morning everybody, and welcome to this RCPCH webinar on health promotion, what's a paediatrician to do. Today's presenters are Dr. Max Davey, RCPCH Officer for Health Promotion, and Dr. Lizzie Wortley, who's an SD6 in General Paediatrics. The presentation will last for approximately 30 minutes, after which we'll be open to questions from the floor. To submit a question for the speakers, if you can use the questions tab on your screen of the GoToWebinar software, and we'll take them accordingly. If we run out of time and your question hasn't yet been asked, we'll be able to respond to your question through email. But without further ado, I'll now hand over to Max to start the presentation.
Thank you very much. So yes, I'm Max Davey. I generally work in Lambeth in South London as a community paediatrician, but I'm here as our health promotion guy at the college. Health promotion is often traditionally defined as the helping the provision of care to help people make choices in order to improve their own health. And this kind of image really depicts that, the fact that we view health as being determined not just by the presence or absence of illness, but also by a variety of lifestyle factors. So if only people would eat less and smoke less, exercise more, and be less stressed, then actually a lot of our problems would be solved. So in one way, that's the answer. That's your hour's webinar. You just have to tell people to do that. The difficulty is that approach doesn't work, and several reasons why it doesn't work. One is several of the things that are actually in this Facebook meme that I've picked up from that website are not actually accurate. So we need to be evidence-based. So it doesn't actually matter whether you eat organic fruit or veg. It makes no difference at all to your health outcomes. Ditching your TV is obviously, and the other thing we need to be is realistic. Ditching your TV is unrealistic for most families that we work with. So we need to be realistic about what advice and what changes we think people can make. And the third reason is it doesn't take any account of what where the family is, where the child is, where the parent is, and what constraints there are over what choice they can make. Quite clearly, to take an example, avoiding processed foods. Well, what on earth does that actually mean? And is that actually possible within the budgets, particularly when you're working somewhere like London or any sort of urban area? What the availability of fresh fruit, just in terms of it being in the shops, but also it being affordable. Those sorts of things are really, really important. So I just want to talk about that for the first sort of few minutes, how we stop preaching and start working with families as a bit of an introduction to the topic that Lizzie can then take on. So because there are two truths that I think are important that we have to keep an eye on. So before we get into anything kind of technical or theoretical, at the top of this slide is the things that promote your mental and physical well-being. And they are very, very simple. Sleep, we've had a webinar about sleep from my colleague Mike Farquhar, and it is a vital component of mental and physical health. Exercise is very helpful, both simply from the point of view of expending more calories and so avoiding obesity, but also from a mental health perspective. Exercise is a good public health intervention, although as a treatment intervention, there's not good evidence for it for a mental health illness. But the other thing is of course social contact. Now the question becomes, what do you mean by social contact? Does social contact online count? Actually, the jury is out on that. It does seem that social contact outside of the real world has a different quality to it and may lack some of the advantages of social contact in the real world, but it doesn't lack all advantages. There does seem to be genuine advantages to it, and better than no social contact at all. I'll go into that in more detail when we do our screen time webinar later in the year, but that's a kind of few ideas about that. So any social contact is, the bottom line is any social contact is better than no social contact. There's a lot of health promotion messages around healthy eating, and this is my personal view. I think that's got a little bit complicated, and I think people got very confused about what is and isn't healthy, what foods do and do not are or not health giving, and that's not been helped by an advertising industry that really just exists to confuse people rather than answer questions. If you have avoided obesity and you continue to avoid obesity, you are doing okay, is the bottom line. So anything that will increase, improve the calorie balance of your lifestyle. So decreasing the amount of calories that you're intaking and increasing the calories that you're outputting. That can be exercise in the sense of sport, or it can just be walking to school or getting off the bus a little bit earlier. We forget sometimes these very simple changes because when we're lost in the quite complex 5-a-day healthy plate, these sorts of things that people get a bit overwhelmed by. This is simple stuff that we need to be careful of. However, the second real truth, and this is what's really important about this webinar and also about my work as a health promotion officer, is that people's ability to make these lifestyle choices is significantly constrained by a number of factors. So poverty is a really huge factor. I'll talk a little bit about it in obesity, but we know that if you look across the piece, every single sort of ill health is correlated with poverty, and that cannot be because poor people are inherently weaker or less intelligent. It is due to the condition of poverty. It may have some psychological roots, but it is poverty itself that is the problem we need to tackle here. The other thing is illness and disability. I'm always very struck in my community clinic by the number of mothers generally who come in who themselves have illness and disability, who have therefore, relatedly, not managed to maintain their children's health in an optimal condition, because actually, we're going to do another webinar on behavior later on. I'll return to this point, but actually bringing up a child to be healthy and to have good behavioral boundaries is a physically demanding physically and also demanding of your attention and your patience, and all of those things are sapped by illness and disability in the parent. The third thing is the built environment. Now, this is obviously very, very relevant for urban environments. It isn't just the availability of parks. Of course, living in London and obviously other cities in the UK, there are wonderful parks, but there's no good at all if, like in many of the areas where I work, the families simply don't feel safe being outside, and so they're inside, not expending calories, not spending time out in the outdoors, and therefore all of the missing out on all of that. So actually looking at the built environment with the local authority, looking at the availability of leisure with the local authority is a core part of health promotion, and simply just telling people to go isn't enough. And the final thing is isolation. Now, obviously, this is relevant for a rural population, people who don't get the social contact that you need, but actually it's very easy also in an urban population, particularly a quite diverse population where you perhaps don't fit in with other people around you, very easy to become isolated. Again, if you are a parent, or one or both parents have mental health problems, then that isolation can greatly increase. So just to kind of illustrate that point with a particularly stark example, which I make no apology for using a local area to where I work, Southwark. So this is just over the border from my borough. In Camberwell Green, and this is genuinely the first image that came up when I looked up Camberwell on Google Images when I made this slide, which is a police scene, obviously, as you can see, that 30% of the children and young people are obese. Between Camberwell Green and Dulwich Village is a 10-minute cycle ride. I can tell you from experience. And in Dulwich, and this is of course the first Google image for Dulwich, which is Dulwich College, there's a 10% rate of obesity. So you cannot say that is simply because people in Camberwell make 3 times worse choices in isolation. You've got to look at the availability of fresh food. You've got to look at the affordability of fresh food, the what is available in the shops. You go into Camberwell, you can get 5 donuts for a pound, for which you can get maybe 2 apples if you're lucky. So those are the sorts of choices that are being made. Equally, Dulwich has got a wonderful park where which is always full of people. Camberwell's parks are less accessible, less good, and more dangerous. So all of those things are playing into it. In Dulwich, there's lots of brilliant cycle lanes, and the active transport is actually very easy. It's not in Camberwell. I tend to avoid it on my bicycle, and I'm sure other cyclists do too. They try to get the back roads. So and that's as an adult. So the point about this slide is that if you look at gradients in obesity, health promotion is a political issue. It's not a party political issue, and we don't want to take sides between particular parties, but it is a political issue. It's something that's local politics and national politics needs to be taken seriously. If you take the national perspective, we are making good progress in more affluent areas against child obesity. That seems to be flattening out. The areas where we are not making progress is areas like Camberwell, poor areas, and the gap is widening between these areas and the affluent areas. The difficulty is that if we don't appreciate the way that people's choices are constrained, the political conversation becomes around the unworthy poor, or people bad choices, and that's not helping, because it feeds that back down to the individual level, to how people feel that they are being seen by the professional who's seeing them. If people think they're being seen at, if they have an obese child and they think they're being seen as a feckless parent, that will immediately come through in your consultation with them. So it's very important to do health promotion in a way that doesn't annoy people. And it's not very, so Lizzie's going to talk a little bit about the challenge of fitting it in. I'm going to talk about the challenge of doing it in a way that isn't patronizing. The first thing to say, and this might not be obvious, actually saying, if someone is struggling and they're finding things very difficult, saying I know exactly how you feel is actually exactly the wrong thing to say. This is just a tip, really, that you do not know where they come from. You do not know their history, and you sort of need to, rather than, you don't have to sit down and spend an hour hearing their social history and their life story, but you do need to have respect for where they come from and why they've made the decisions that they have. The other thing, sorry, I've gone back. The other thing that I really think we should avoid is this idea that Google or information from the internet, because there's people who come with a stance of not knowing anything and feel like you feel like you as a doctor think that they're stupid in that way. But then there's people who come with a lot of information but not much understanding, and there is a sort of, certainly online, a kind of doctor's movement to kind of not confuse your Google search with my medical degree. And I actually hate that. I think that's completely wrong, because what people have is information, and they have a great understanding of their own life and their own circumstances. What you have as your medical degree is a way of contextualizing that information that they have, connecting it with their own experience. And so in fact, rather than being a kind of guide, you're an interpreter. And obviously that does take a little bit more attention, a little bit more time, but actually it does result in people going away feeling like they've been listened to. And that's the only way that you're going to make a difference. If you just say, here are the messages, go away and do it, it's not going to happen. We know psychologically that people don't respond in that way. So you need to respect the fact that they've Googled stuff, and not dismiss it. So that's the two things I do want to say. And I rather surprised myself by using a Bob Marley quote, because I was looking for something else, but actually it does crop up quite nice. It did pop up, and I think he's kind of, because his tunes are so jaunty, it's forgotten how much he understood poverty, and he understood race, and he understood politics. And so actually, so if you know your history, you know where you're coming from, and then you don't have to ask people, because you don't have to assume you know them. You just have to know where they come from and know what they're about. And I think that is quite important, actually. But equally, I know I've talked for my 15 minutes and talked about lots of different things. You're going to bring back to keeping it simple. So the things that actually help are really simple things, really simple changes that people can make, which can only be arrived at by looking at where they are. You can't impose them unless you know where the family is now. So making very simple changes on very simple things and not blinding them with science is the way that I think we should be starting to do health promotion. It's not easy, but it is much more effective than the kind of preaching that I think has been rather a part of our history. I'm going to now hand over to Lizzie. Lizzie, are you going to come over to this computer? Okay.
Hi, I'm Lizzie Wortley. I'm one of the paediatric trainees in London, and I'm going to talk a little bit about mapping this to the curriculum and the resources we have and how you can develop skills in this area. The feedback I usually get is we just don't have time to have these conversations with people. So we're going to talk a little bit about how we can do that today and other ways you can bring these competencies and skills into your learning throughout your training. So this is a picture of the curriculum. I don't really want to go into it in detail, but level 1 is about promoting healthy behaviour in young people. So that's about your one-to-one interactions with families, which Max has covered in a way not to be patronising. And I'm going to come back to this later in other ways you can do this, because I think that being able to rethink level 2 and level 3 when you're talking about cultural, social factors on child and family health allows you then to do the talking one-to-one with people in a lot better, because you have a greater understanding of what's actually going on, which is exactly what Max was talking about. So level 2 is considering the potential impact of cultural, social, religious and economic factors on child and family health. So I've got a few ideas here as to how you can do this, and you can either do this as an individual, or I think what works better is to add it into your kind of weekly or monthly teaching sessions. So what we've got up here, the strip across the top with the color coding, is from what's called the Fingertips website, and this is run by Public Health England, and you can put your county in here. So I've put in Hertfordshire, and you can see how you're doing on multiple factors. So I've just taken the top 3, which is infant mortality, child mortality and vaccination coverage. So you can see in Hertfordshire they're doing pretty well on the mortalities and middle ground for MMR coverage. And you can use this really easily in a teaching session. You just go onto the website as it is there, put in your local borough for your hospital, and everyone in the room can immediately see what are the things that your local area may be struggling with compared to the rest of the nation. Now, because this is a comparison with the rest of the nation, you might look really good at something that pan-Europe we might not think is particularly good, but it gives you an idea on what might be the top 5 things that are really bad for you, like dental health, childhood obesity, 4 to 5-year-olds, or maybe mortality rates in your area. And then as a team, you really open up the conversation about other things you might want to do in your department that could help these things. I know when we've done it with our team, even the consultants have been shocked at what the figures have shown, because it's not something we're talking about day to day. And the whole point of this webinar is to open up the conversation about the things that we don't talk about day to day, but for our patients are having an impact on everything that they do, but we don't necessarily see as doctors when we're in our nice contained spaces. So my first question to you is, what do you actually know about the local community you're serving? So Fingertips is a great place to start. Then you can look on your council website and you can have a look for the health and wellbeing boards, which meet about every 3 months. And they discuss all the local issues, and they should have a strategy and priority plan. And you can have a quick look at your strategy plan, and most of them have bullet points about what are the top 5 things that they're trying to change locally, and you can see what you're doing in your department that might be having an impact on that. So that's on a kind of big pan area way of looking at what's going on, but there's also 3 thought experiments you can do that we sometimes do at work. And the first one is, how are people getting an appointment with you? So we often complain about children who weren't brought, but what do we actually know about the context in which they weren't brought? So if you go onto something like Google Maps or City Mapper, you can look at your local area and see how many buses the average family would have to take to get to your hospital. So if my hospital is often 2 or 3 buses that people have to get. So if you take the cost of bus travel, you factor in the fact that if you've got a pushchair, you're sometimes not allowed on the bus because there's already a wheelchair on there or there are other pushchairs. Then you have to factor in the amount of travel time that parents might need. Also, have a think about parents who are working. Are they allowed that time off work? Some parents may not have a particularly good relationship with the schools, and the school might say that they're not allowed to take their child out of school, or the parent's too scared to ask whether or not they can take their child out of school. That's all just getting into the appointment in the first place. Beyond that, you have whether or not they've made it to the GP and being able to express the problem that they're having in a way that then means the GP thinks that they do need a referral onto further services. So lots of parents who might have difficulty with language, or parents who might have difficulty with communication, are a lot less likely to get the appointments with the people they need because they have difficulty expressing themselves to the GP. And then finally, that you have to have a stable address for these letters to go to. If you think how long it is from the GP writing the letter to the hospital asking for the appointment, and then the hospital getting back to the family and saying when the appointment is, you've got to be in that address for long enough that you receive that letter. You've then got to be able to read that letter, and you've got to be able to read it in English, and you've got to have a good enough understanding of time and place and how you're going to get places to then get to the hospital and navigate yourself around the hospital. So when you think about it in that context, which has only taken a couple of minutes, discussing this with your colleagues and ways that you can reduce the difficulties for parents is really helpful. So some hospitals have set up paediatric clinics in their local GPs to reduce the amount of problems parents have accessing hospital appointments. But I think if you really think about what parents are going through in order to come and see you in your clinic or your hospital, then it slightly changes the context in which we have these conversations. The second thought experiment is one that Max was talking about, which is how do you get to the park to play? So Max covered whether or not the park is even safe or anywhere near you, but I also want to add in things that parents might struggle with. So if you're a parent with 1 or 2 children and you're trying to have you want to have a good life for them, you want to feed them well, then that involves doing some cooking. But if you also want to take your child outside and you don't have a garden, then every time you want to take your child outside, what you're saying is that you are not going to cook anything, you're not going to do the washing, you're not going to do the cleaning, you're going to take yourself and your child outside, and once you're outside in the park, you can't be doing anything else. So thinking about the families where they have gardens, they're a completely different level from the families that have to use parks because of what else the parents can achieve whilst they're around the house, and we often don't think about that context. Okay, and the third thought experiment is, I've completely lost it now. Nope, that's the far as I've got. So we've done the appointments, we've done what you're doing to play in the park. Okay, so that's what I wanted to say about level 2, is starting to understand your local area, starting to understand the cultural, social and religious factors is not difficult. There are websites that can help you. The council have done a lot of it for you. You can think about the demographics that are coming into your department and you can talk to them. A lot of social groups do have community leaders that want to talk to people about how you can best impact on local people's health. One of the best things I ever went to at the Royal College of Physicians was a panel of people talking about their experiences of health and how different groups access health. So had people from traveller community, people from the Jewish community and people from Chinese community talking about their cultures and beliefs and what impact that has on their ability to access healthcare in the way that we deliver it. So my learning point from the level 2 curriculum is that the way that we deliver healthcare is not necessarily the way that people can easily access healthcare, and being more aware of that in your department is a really important thing. So then we're on to level 3, which is demonstrating leadership in the promotion of health and well-being and in the wider community. So if you go onto the RCPCH curriculum domain 5, domain of the month, there's a presentation on there that takes you through the curriculum and all the some ways that you can access this. And the suggestion for level 3 is that you can write a guideline or a protocol or do an audit, which I think is a good, easy way to start demonstrating your leadership skills in this area. But I think one of the things I'd really recommend is if you're ever at a point in your career where you're going to be in one of your jobs for more than 6 months, then this is an opportunity to start building relationships. So actually for children, the people that they see that have an impact on their well-being is actually really unlikely to be a doctor. It's much more likely to be someone else, like their teacher or the health visitor or their GP or someone else that they're seeing on a regular basis, or even their parents. So building up long-term relationships between ourselves as paediatricians and the other people involved in children's wellbeing is really important. And at the end of the day, we can talk about all sorts of things and all sorts of ways we can go about making change, but most successful change is because people have built up relationships and people are willing to work together. So we've got some examples here of how you can start building up relationships with your local community. So one of the simple, well, I say simple, it's not always simple, but if you have some consultants who are on board with you and some interested local GPs, then I'd suggest something like learning together clinics, where the paediatric trainees go and join up with the GP trainees and deliver paediatric services in the local GP surgery. It's a great way to get to know your local area. It's also a great way to get to know your local GPs. You can then talk about any other problems the GPs are having. You have links back to the hospital, and it's a good way to foster relationships. The other thing is whether or not you've ever visited a children's centre. It's amazing how many of us in paediatrics haven't visited children's centres and don't really know what goes on there with the health visitors. The health visitors and the school nurses are absolutely fundamental to the way we deliver child health, particularly child health promotion. And so seeing what they're doing and what it is that they are getting up to every day, the way they deliver their information to parents, the way they engage parents, I think is a really useful thing to do. And you can just ask them, and most children's centres are very happy to have an interested paediatrician come along and see what's going on. Then you've got the school nurses and teachers. So there is the Healthy Schools programme, and often schools would be absolutely love it if paediatricians came in and spoke to their children about health issues. Often teachers are a bit nervous about being the one that talks about sex or bullying and things like that. So they may be looking for people to come in from outside to have these conversations with people. So you can get involved in that. Mental health services, so contacting your local CAM services and seeing if it's possible to shadow any of them and get a better idea of what exactly is going on. And third sector groups, so lots of third sector groups deliver mental health services and other family support services around. Getting to know what's available in your local area. There are websites now that tell you what groups are available to support families, and being able to know some of those is really helpful, because then when parents do have a question about these things, you can tell them about it. Things like parenting classes and support for children with autism and ADHD, knowing where you can signpost people, particularly when we don't have services for them ourselves, is really helpful and actually much more beneficial to them than saying, sorry, there's nothing else we can do, or you can Google it. So if we already know this stuff for them, then we're saving parents so much hassle. And then the final group of people that I can think of, but you might be able to think of many more, are the public health teams. So your friendly local authority has a public health team that are really keen to link up with active acute paediatricians, because we're all actually trying to achieve the same thing. So having conversations with them, I'd invite these people to teaching sessions, to if you have a paediatric grand round or something at your hospital, get people in to have a chat about what's going on and hear from the horse's mouth what's really happening. And the other thing is to get parent groups as part of your service, so and children and young people's groups. So start opening out the conversation with the people you're trying to help about what you could actually do, change, or maybe just tweak just a little bit that would actually make a massive difference for them. So so now I've got some resources, and going back to level 1, I'm just going to go down a slide, talking about techniques you can use to actually start the conversation. Many of you will have heard of the HEADS assessment, which is stands for home, education, eating, activities, drugs and alcohol, and then safety, social media, sleep, suicide, and sex. So you can have many, many S's on the end there. And that's just simple, quick questions you can ask people to get an idea about exactly how things might be going in life, and then you can follow the conversation as it develops. My response to people who say we don't have time to do this is, well, perhaps your abdominal pain or your headache or your reason for coming to A&E is actually going to come out in these questions rather than ignoring that idea. There's also motivational interviewing, where you're trying to get people rather than you tell people how to change, you explore what's going on for people and whether or not they're ready to make a change, and then help support them in that change. There's the behavior change wheel theory. There's something called a bioecogram, where you can start mapping exactly what's going on for a family. So what is the accommodation like that they live in? What's the impact? What's their family budget for food? Start having these kind of conversations. You don't have to be a genius about it, but a lot of people feel better for having had the conversation and being able to be open about it. And then they can start thinking about the ways they might be able to change things in their life. And there's something called Conversations Inviting Change, which is a group that are looking to get clinicians to listen more to people's stories and use that to change the way that they interact with people, and they come up with care plans for them, rather than us being pretending not to be paternalistic when really we are paternalistic. So there's also some courses you can go on. So there's RCPCH courses on how to manage childhood obesity. There's one coming up on health promotion for vaccines. There's one coming up, we've had one on sleep. There's another one coming up on behavior. And so these are webinars. There's a couple of days course at Imperial College on child public health and social medicine. And at the RCPCH conference, we're going to be doing a workshop on health promotion. And then other sources of information are the British Association of Child and Adolescent Public Health, the Fingertips website, which I talked about earlier. For your learning, the Domain 5 Domain of the Month page, it's got lots of resources in it, and the presentation they have on there has within it more resources itself. There's a couple of papers, one from Education and Practice. There was another recent one in Education and Practice about talking to adolescents, that are really useful to help you slightly rethink what your role is as a paediatrician and how you can start thinking beyond the immediate presentation in front of you to help the child reach their full potential. And then I've just put on a YouTube video that's inspirational for being what we call an upstreamist, and this is by Richa Manchada, about what they're doing in the States to get social workers more involved in health, to actually impact on the things that are either preventing people taking their medications or preventing them being able to be as healthy as they could be. And that's what I've got. Thanks.
Okay, thank you very much to Max and to Lizzie for that really practical presentation. We're now open to questions from the floor. So as I said at the start, if you can submit your questions through the questions tab, and we'll take them in order. While we're waiting for some questions to come through, just as Max and Lizzie have said, just to let you know, this is the first in a series of health promotions webinars that we're running. Some dates for your diaries, and they'll be open to book soon if you go onto the RCPCH website webinars page. 7th of March, we have a webinar on immunisation with Professor Helen Bedford and Dr. David Ellerman. We then, on the 12th of March, have a presentation again from Max on screen time. 11th of June, we'll have one on behavioural paediatrics from Max, and in the autumn we'll have one on oral health. As Max has said, we also have had a webinar on sleep, which is already available in the Compass webinar archive section. So they're just some dates and topics for your diaries going forward. But open to questions. One of the first questions that's come through is health promotion really relevant to my practice?
I'll take that one. Medical practice is a process of gathering information in order to form a plan that is going to help the patient in front of you. That's the beginning and end of it. If you are willing to invest your time in getting information regarding the child's biochemical makeup, the various bits of imaging, it is also, which may or may not be relevant to the symptoms that you are experiencing, it is also relevant to gather information about the child's social background, about their social context, because we know we have very good, robust data which indicates that these are relevant to a wide variety of different presentations. Now, occasionally, of course, we are looking for one particular cause, and we treat that cause, and away we go. Great. But more often, and I would say increasingly often, the practice of pediatrics is a practice of finding multiple factors that may be underlying the symptoms, and addressing those in a pragmatic way. And health promotion is absolutely at the heart of that. You can't actually practice, I think, good pediatrics outside of a very few isolated, quite straightforward situations. Anything which is complex in pediatrics requires health promotion as part of the clinical approach. And I perhaps didn't make that clear enough in my presentation, but that is what I believe. Lizzie, do you have anything to add to that?
I would agree. I'd say 100%. There's so much that we see when you actually drill down. Things like even your asthma patients, not just the housing that they live in, but whether or not they're even in a space where they're capable of taking their medications because of what else is going on in their life. And my final thought is it's 10 years since the Marmot report and Michael Marmot's work. If you haven't read it, then I'd highly recommend it. It's all about how your social situation and cultural situation impact not only on your current health, but on your health over a lifetime, has impacts on your DNA and what you pass on to future generations. And so this is not something that we can ignore. It is coming round to bite us in the proverbial as we speak. So we highly recommend it.
Thank you. As part of your presentation, Lizzie, you referenced Public Health England website.
Yeah.
Do either of you have any recommendations for links for that kind of data in Scotland, Wales or Northern Ireland? Or do you want to think about it?
I do need to think about it. There's an NHS Scotland website, because NHS Scotland sets itself up slightly differently and is less split up, frankly, and more integrated. So the NHS Scotland website incorporates the public health data within the overall website. So and actually, having looked at some of this before, I'm not speaking from total ignorance. Therefore, the NHS Scotland website is a very good source in and of itself. The Welsh, I think the Welsh, actually the Welsh have got a really good record on public health and public health advocacy, and I suspect your best bet in Wales is to go to the Welsh Assembly website as a first port of call. But we can have a look and we can get back to you by email about those things. It's an excellent question, of course.
Thank you. We have a question that's come through. I am a community paediatrician covering an area of urban deprivation. I jointly established a local child obesity intervention that was closed down during the previous cost improvement programme. How do we advocate for programmes if local PHE and I are struggling for seed funding for fresh initiatives?
I think you have to demonstrate that they work. And I think that's the problem you have, is that you are dealing with a multifaceted problem where you are trying to change one of those facets, and it's very, very difficult to show impact. I think the honest truth is that you can only do obesity intervention as a local area. I think you need to get from the very top of the local authority buy-in to intervention into child obesity, and you need to look at all levels, so active transport, active travel, the availability of takeaways, and as well as information and intervention. So it's a slightly difficult question to answer, but it depends on your intervention. But I think the only sustainable way to push these things forward is as a multi-agency local area team, because actually if you look at the data, some of the most effective interventions, such as in Amsterdam, have been at the level of a local area rather than individual or even 2 or 3 agencies working together. It's got to be buy-in of the whole local health environment, basically. Liz, do you have anything to add to that?
My only thing would be that we can all go to the health and wellbeing boards of any area and walk into them and start a conversation with people. And my second thing would be, having tried to have a look at this in our local area, would be the use of third parties. So there's lots of more charities around than we ever imagine who are also trying to do similar things. So getting to know your local third parties who might be interested in this, and might be a way to deliver some interventions whilst the local authority are looking at the bigger picture. As Max says, it needs to be from higher up often.
The other thing to mention is that the government is moving, although perhaps a little slower than we'd like to, on this in terms of their obesity strategy. So have a look and see if there's anything helpful in the obesity strategy, which is currently on chapter 2, which might persuade local authority to take more action, or the public health, somewhere to find someone to find some money somewhere, because they are sort of mandating it from above, although they're not necessarily providing money centrally for these interventions. They're very much they're delegating quite a lot of the work to local authorities.
Thank you. You touched upon it in your presentation a little bit, but what about mental health and promotion around mental health?
I think the messages around mental health are the same as the messages around physical health. I think we shouldn't really necessarily split it off. Sleep, exercise, social contact, and avoiding obesity are all good for your mental health. One of the main concerns, of course, and we'll go back to it in a few months, is the impact of social media and screens on mental health. And again, it's a question of balancing those against the things that you want them to do, which are those simple things I've just talked about. It's having a life which allows you to have social contact, sleep, and exercise. Those are the things that you need. And again, it's also about keeping it simple and avoiding any kind of scapegoating or simplistic narrative around, oh, they've got this mental health because they saw this thing, or they've got this mental health problem because their school is wrong. It's not that. It'll always be a multiple different things. But I suppose the one thing that just occurs to me, if you're thinking about mental health and health promotion, we probably do need to think about bullying as a really significant factor in mental health. That's usually in person, although it does happen online. So I suppose that's the one thing to add is the avoidance of bullying as a factor in mental health. So yes, thank you for that question.
And following on from that, you also mentioned briefly that there's going to be a webinar on oral health. Do paediatricians have a role in promotion around oral health?
We do. Lizzie, do you want to take this one, or?
Yeah, I think that we do. As part of your examination, we often look in the mouth, and I think asking questions about, are you brushing your teeth? What do you usually do as part of your bedtime routine? Trying to keep open questions that don't sound particularly judgmental is really helpful. Oral health does have an impact on physical health, and conversations around diet and such like do involve oral health as well. I think sometimes it can not feel like part of your job because we all assume the dentists are doing it. But I think the simplest thing we can do is have a look at the teeth, see if there are any problems there, and promote people seeing their dentists and letting parents know that that their children do have a right to be signed up to dentists. The British Dental Association are doing lots around this at the moment and trying to improve things. And we've got a webinar coming up in the autumn, particularly about dental health.
Thanks very much for that. We have another question that's come through. Thanking you for your interesting talk, but can you highlight the new points or updates on the component of health promotion that needs to be addressed? I found that most of the points highlighted have already taken place and are well documented in the real system. It may be a question about changes from the old to the new curriculum, potentially, and any new things that have come up in the new progress curriculum.
Yeah, I mean, we weren't trying to reinvent the wheel in the progress curriculum, and I think the other key thing about the progress curriculum is it is reviewable. And as the environment in which young children are growing up changes, we will change the progress curriculum. We will check, apart from at the very top level, we'll change the illustrations. We'll change the key capabilities. Thank you for that word. Over time. So yes, I mean, any input that people have that they think, why are we not being taught to do this? We can't guarantee that it will go immediately into it, but that the point of progress is that the GMC have given us much more flexibility than we ever had in the old curriculum over the content. So yeah, definitely we can have a look at that. If your question was about something completely different, please rephrase it and put it back in.
Thank you, that's really helpful. Another question, again, I think you've touched upon it in your presentation, but again, it's bringing up this point of not patronising families and children and young people when giving health promotion advice. Any further tips that you might have?
I think it's a lot about your attitude. I think it's a lot about asking questions, spending a lot of time asking questions and a very small amount of time giving advice. and if possible, getting people to come up with their own ideas of how things could be better. So if people, you just need to show a little chink, and people say, I know we should do more exercise, but, and then let them finish their sentence, and they go, well, you said earlier about wanting more exercise. How do you think this might be? How do you think this might be improved?
So I would add that some of the things like the motivational interviewing and the conversations around change, those are all designed in order to avoid this problem where you're kind of preaching to people rather than supporting people to go from the space they actually realistically are at to the space they want to be in. And I've remembered my third thought experiment, which is the child going to school. So you can promote the child walks to school, but think about what that walk to school is and how many fast food places are they going past, how many corner shops are they going past. So we can all be advising kids to do one thing that sounds great, but that might actually add in a whole new level of complexity for that individual. They have to make the decision every time they walk past one of those places not to, give in inverted commas and get the chips or whatever it might be that they're trying to avoid.
Thank you. And in terms of further kind of training and learning, Lizzie, on your slides, you referenced that there's going to be a workshop at the annual conference. Would you like to say a bit more about what you're planning to cover?
So Max and I will be continuing along the same theme about how how in your normal paediatric practice, you can start doing more health promotion. So I think this is coming from a place that, as Max has said, there's very few conditions where lifestyle and your situation don't impact on your outcomes. And we're really aware of this. And I think there's more and more evidence coming forward all the time that this is the real crux of where medicine is going for all specialties, and that there isn't really any way to avoid this. But the reality is we're all very busy, services are very stretched at the moment, and people are feeling like every minute counts. And do these conversations really matter? So what we're hoping to do is to continue this conversation and give a few more ideas and hints and tips, and to open it up to the floor about other people's ideas about what you can do in each and every consultation to expand that conversation a little bit further and help improve the health for the child in front of you.
Thank you. A final question that's come through. Do you have any tips for paediatricians working in emergency departments in how to pick up the health promotions agenda? What can they do?
So I think this is often a really difficult one. I think my first piece of advice is just allow the conversation to happen. So we often have our own agenda in the emergency department. People might hand you a set of notes and just say this should be a quick one, or some such, or these guys are always here, there's never anything wrong, kind of get them out the door. Though I would say that to me is a red flag, that I actually need to be spending a bit more time with these people to delve into what's going on, because I don't want to be seeing them every week in the A&E department, and that rather than send people back to their GPs, not many of them are being trained in paediatrics anymore. So I feel like we have more of a responsibility to make sure that when we are seeing the patient in front of us, that we're delivering for them the best possible care. And in my head, the best possible care is to find out what really is going on. Why do they keep coming back with their abdominal pain? I know that's always my example, but that tends to be the classic one. And what else is going on? One of the pieces of feedback I've had from colleagues in the past is not only that they don't have the time to do it, but that they might open a can of worms that they don't really want to deal with in the emergency department there and then. So that's where I'd say this is where understanding your local area and what other services are available is really helpful. So particularly from the mental health point of view, you do have school counsellors, they can see their GP. There's a really great set of videos called #NoHarmDone about mental health in young people. And the main message from that is just starting the conversation is helpful, not harmful. So please, can we just start these conversations, and then you can direct people as may be needed from there, but not to be scared of having the conversation in the first place. That would be my main tip. And secondly, Yeah, time is a really, really difficult one, but I really feel that these things can just be 30 seconds or a minute, and it's about your attitude and the way you carry yourself to allow the child to feel like they can open up to you, and that doesn't take any extra time at all.
I would just echo what Lizzie said. It's about attitude. It's about whether your attitude is, I want to find the pathology, and if there isn't any pathology, I want them out. Or if your attitude is, I want to find out what's going on here and how I can help. And that sounds preachy from me, but I promise you, I don't work in A&E anymore. I don't work. That's how old I am. I still call it A&E. But I was always quick, and I was always interested in this stuff. So you don't have to be slow and meticulous and kind of, you know, ponderous in order to do this. Just being interested in how they've come to where they are. It actually can save you time, because you don't have to, if you've got a convincing story which doesn't involve something clever or some kind of rare pathology, you don't actually necessarily have to investigate. It can actually cut your investigations down quite a lot.
Yeah, the Atul Gawande's done a brilliant piece in the New Yorker in the last few months called something to do with curiosity, and I would totally agree with Max. Maintaining your curiosity as a doctor not only helps you to have these conversations with people, but it just makes life more interesting. It's just much more interesting to see young people when you actually have a decent conversation with them than when you're going through your tick box and trying to get them out of your clinic room or department.
Thanks to both of you. That's the end of the questions from the webinar. If anybody has any further questions after having watched this webinar, you're very welcome to send them through to education.provision@rcpch.ac.uk, and we'll forward them on to the speakers to respond to. But as there are no further questions, I'd just like to take this opportunity to thank Max and Lizzie once again for a fantastic presentation and a really detailed Q&A session. And also to thank you in the ether for joining us for the webinar today. As you'll see on your screens, if you'd like to give feedback on the webinar today, you can provide feedback through the first link. If you would like to access other webinars that have already been recorded, or if you'd like to book onto future webinars, some of which we've mentioned already today, you can do that through the second link, both of which take you to the RCPCH Compass website. But thanks again for your time. Enjoy the rest of your day.